Our next speaker is Dr. Ramesh Dorairajan, sir. He'll be speaking on secondary and piggyback IOLs. Alpar calculation.
So I think we'll pool together questions. Let all the talks be over, and then if there are any questions from the audience, we will take them up. So that way we will be able to keep to our time limits. If you want to, you can just jot down the questions and send the questions to us.
Thanks, Arup, for asking me to talk about secondary and piggyback IOLs. So the location of the secondary IOL can be in the anterior chamber, front to back, retro iris fixated, sulcus in the bag, or it can be scleral fixated. Piggyback lenses are usually in the bag or in the sulcus, so it's a more easier proposition. iWiki says that the reasons for secondary and piggyback IOLs are these, but for most of us, number 3, after complicated cataract surgery, forms the bulk of our reasons for putting an implant. We have a surgery where we have complication, we have PCR, and we tend to postpone, and then we do it. A good friend of mine who has a large volume teaching program for postgraduates, who does somewhere about 8 to 10 secondary IOLs every week, tells me that if you're not prepared, if you're not experienced or prepared and don't have the proper equipment, please don't rush and put a secondary IOL. Tell the patient that half the surgery has been done, cataract has been removed. We'll put the lens and wait for the cornea to clear, wait for the eye to settle, and do it anywhere 3 or 5 days later. So don't rush with your secondary IOL, and he gets very good results. So this is a take-home point. Tell the patient half the surgery is over, and you'll do the remaining half when the eye clears up a bit. In the Western series, the commonest causes are incorrect IOL power, IOL luxation, opacification of IOL, photopsias, and dissatisfied patient with multifocal IOLs. In this large series from Greece, they found that 75% of the secondary IOLs were for IOL dislocation, around 20% was for aphakia. This group is a group which had surgical complications and the patient was left aphakic, and 6% was for IOL opacification, something which you don't talk about at all, but that people are explanting foldable IOLs because they become opaque. Primary piggyback IOLs is done when we don't have a lens with enough power in severe axial hyperopia. This was common earlier, but now with most manufacturers making very high power lenses, it's not really an issue now. Secondary piggyback IOLs are usually implanted for post-op ametropia, and the options include monofocal, and we also have toric and multifocal options. And these are hydrophilic lenses which can be slipped into the sulcus over the initial intraocular lens. So secondary piggyback lens is usually done for a refractive purpose. Rarely, secondary piggybacks have been done in small series for severe negative dysphotopsia with reasonably good results. The best location for a secondary implant is obviously in the bag if you have sufficient bag, and or in the sulcus. The other options that we normally have to resort to are AC, iris fixation, and scleral fixation. Most studies show that no one method is superior to the other. But this particular series from Greece does show that you have more chance of losing 3 or more lines if you are fixing it if you are doing a scleral fixation. And these tall lines, if you put it in the anterior chamber, the clear one, if you put it in the bag or in the sulcus, you have more chance of getting three lines or more. So how do you calculate the power in these different locations? For in the bag and scleral fixation, please use your normal calculation. If you're going to put a sulcus implant or an iris fixated IOL, calculate for the bag, and then you have to adjust as per the following table from Dr. Warren Hill's site. So most of our patients are going to have between 17 and 28, so you just reduce 1 diopter because you're shifting the plane of the intraocular lens slightly in front. If you have a very high plus lens, like a plus 28 or more, you have to reduce a bag calculation by 1.5 diopter. If you have a highly myopic eye, the calculation for the sulcus, the iris fixation, and for the bag will tend to be the same. So less than 10, implant the same lens. This is the rule of the thumb. For AC IOLs, just go and use the manufacturer's A constant. So for piggyback IOLs and for aphakia, the ELP tends to change depending on the location of the lens. And the refractive divergence calculator from Warren Hill's site, this is actually very easy, though it looks very, very complicated. All you have to enter is the K1, you have to enter the K2, and you have to enter the preoperative power. So if you have a patient who accepts 3.25 for plano, and you want a post-op minus 0.25, it will give you a power of 5. So you just have to know K1, K2 and what the acceptance is to use the refractive vergence calculator. It's not complex. There are clear instructions. Please go to Dr. Hill's site and then he'll tell you how to do it. For most secondary IOLs, the go-to formula is what Dr. Arup told us in the beginning during his talk. The Barrett suite of formulas also has a outcome analysis or the Barrett RX formula. Here, please see the top. You have the patient data on top. Okay. By the side, you have the next option. If you want to exchange the lens, and then you have the piggyback lens formula. So this makes it very, very simple. So you enter your usual K1, K2, and your axial length and the power that you have, and it will tell you whether you can rotate your current intraocular lens or you have to exchange it. So here is an example of a 82-year-old physician who had lens implant done by a good friend of mine. He had 6/9 vision through a small zone there. He had 6/9 vision, but he wanted to read the Hindu and the whole lancets. So he wanted to have better vision. So I did cataract in the fellow eye, because the fellow eye had a simple cataract. But then after the fellow eye was done, he still wanted something to be done for this eye. And here you can see that he has a little bit of vitreous peeping through the small PCR here, which has caused and then the previous surgeon has put a nice lens in the eye, but he has severe fibrosis and upward dislocation. So in this particular patient, I removed the lens, did an anterior vitrectomy, and then did a scleral fixated lens using a standard calculation. And here you can see the scar of the Hoffman pocket, which was created. And the iris hooks were used, so the pupil has become a little larger, but basically he got 6/9 uncorrected and he's reasonably happy. So here is one more patient who had surgery done several years ago. I think it was about 15 years ago, and she had a +8 pre-op, and the initial power that I put was not sufficient, so I put a piggyback lens in the eye. She came for a review 2 or 3 weeks ago, so I took this movie, and these are 2 PMMA lenses from Appasamy Associates, and she's quite happy. But this reason, that is high ametropia and inadequate lens power, is not really needed now, because we get very high power very easily. So in summary, use the Barrett RX formula. Also think of the refractive vergence formula from Dr. Hill, and custom power for extreme hyperopia is possible now, and please consult your local IOL manufacturer.